Hello learners, welcome to lecture 44. In our previous session, we discussed social action and advocacy for reproductive and child health rights, focusing on how communities can mobilize and influence policy. Today, we will shift our focus to the role of NGOs and civil society in RCH. These actors have historically filled gaps left by governments, piloted innovative models, and amplified the voice of marginalized groups. In this lecture, we will analyze their contributions, strengths, challenges, and future directions in ensuring equitable reproductive and child health services. Non governmental organizations and civil society groups are indispensable in the field of reproductive and child health. They complement government programs by delivering services in underserved areas, advocating for rights, and experimenting with innovative models. Civil society, through grassroots mobilization and advocacy, ensures that communities are active participants in shaping health services. Together, NGO and civil society serve as both service providers and watchdogs. Historically, NGOs were among the first to bring health services to underserved, rural, and urban areas. Before governments could expand programs widely, NGOs often pioneered community based health approaches. They filled critical service gaps, especially in family planning, maternal care, and immunization. They also gave a voice to the marginalized populations, advocating for policies and recognized their needs. Building on this, NGOs can be considered as norm entrepreneurs and institutional innovators that convert local knowledge into workable delivery models. Trust building, cultural mediation, and last mile logistics that states later adopt through diffusion. Through resource mobilization and social networks, NGOs assemble volunteers, community health workers, and women's groups, demonstrating participatory tactics that shift behaviors and make inequities visible. The classic pilot evidence policy pathway matters. NGO document outcomes, costs, and acceptability. Then translate lessons into policy briefs and training packages that governments can scale. At their best, NGOs practice co production with communities, co designing services, compensation participation, and protecting informed consent and privacy, while advocating rights in the public sphere. Yet, fragmentation and elite capture are risks. Coalitions and clear memoranda of understanding with government help align roles, data standards, and referral pathways so innovations don't remain islands. For sustainability, NGOs define SMART tasks, embed monitoring and community feedback loops, and plan transitions so state systems can institutionalize successful models without losing their equity focus or community trust. Civil society is a broad term encompassing community based organizations, faith based groups, advocacy networks, and social movements. Each plays a unique role in reproductive and child health. For example, faith based groups often provide trusted platforms for awareness and service delivery, while advocacy networks push for systemic reforms. Civil society thus brings diversity and inclusivity to RCH interventions. NGOs span the entire life course in reproductive and child health. They deliver contraceptive counseling and a balanced method mix, run antenatal, interpartal, postpartum services where facilities are scarce, and link newborns to timely immunization and nutrition support. They operationalize adolescent friendly clinics and school or peer programs that provide life skills, menstrual health education, and confidential counseling, reducing stigma and dropouts. Beyond services, NGOs strengthen systems, training frontline workers, fixing last mile logistics, and using community scorecards and grievance channels to make providers accountable. They also act as equity advocates, generating disaggregated evidence and elevating voices of marginalized groups to shape budgets and policies. Partnerships with government converts proven NGO pilots into scalable, right based RCH models while safeguarding consent, privacy, and respectful care. NGOs often deliver direct services through clinics, mobile health units, and trained community health workers. These interventions are especially important in remote or marginalized communities where government services may be limited. By bringing the services closer to people's doorstep, NGOs increase accessibility and build trust. Their grassroots connections ensure services are tailored to community needs. NGOs are recognized as innovators. They pilot new models, such as community based distribution of contraceptives or participatory women's groups for maternal health. Some integrate health with livelihoods, ensuring sustainability. NGOs are also early adopters of digital health tools, testing telemedicine and mobile apps for reproductive health education. Successful models often inspire government adoption and scale up. NGOs act as a norm entrepreneurs and institutional innovators, translating local knowledge into practices that can diffuse across systems while via coalitions and policy networks. Strong pilots pair human centered design with implementation science, tracking outcomes like couple years of protection, antenatal postnatal follow ups, immunization dropouts, stock out days, and time to referral. So, governments see not just promise but proof. Health livelihood integration reduces opportunity costs and builds collective efficacy, making behavior change and service use more durable. Digital innovations, which are equity, should be equity by design. For scale up, NGOs codify models into SOPs, training packages and costing sheets, secure memoranda of understanding and budget lines, and embed indicators in routine HMIS so that state can adopt at volume without losing the model's equity focus or commitment to respectful right-based care. Civil society has been at the forefront of advocacy campaigns for reproductive rights, such as access to contraception or safe abortion. They mobilize communities against harmful practices like early marriage, gender based violence, or sex selective abortion. Through lobbying, petitions, and public campaigns, civil society organizations influence policy reforms and ensure reproductive and child health remains a political priority. NGOs rarely work in isolation. They partner with government programs extending the reach of national initiatives like RCH or ICDS. They collaborate with international donors to access resources and technical expertise. More importantly, they build partnerships within communities, ensuring interventions are grounded in local realities and culturally acceptable. This multi level collaboration makes their work impactful. International NGOs and agencies have played significant roles in reproductive and child health globally. UNICEF and WHO provide technical guidance and policy frameworks. Organizations like Save the Children and CARE implement large scale health programs. Alliances like Gavi strengthen immunization systems. These international actors complement national NGOs, bringing global experience and resources. Building on this, view these actors as epistemic communities that set norms, metrics, and standards, translating evidence into global guidance that countries adapt through policy windows such as budgets and program reviews. Their comparative advantage lies in convening coalitions, de risking innovation, and funding equity focused delivery in hard to reach areas while strengthening supply chains, data systems, and supervision. To avoid policy isomorphism and top down designs, align with country ownership, co create national compacts, finance capacity in ministries and civil society, and embed transition plans so gains persist after the grants end. Measure contribution with smart indicators, disaggregated by gender, caste, class, age, and location to surface inequities. Finally, connect global advocacy to local legitimacy. Fund participatory research, protect consent and privacy, and ensure global investments amplify, not eclipse, national NGO and community voices across the RCH continuum. Seva. This is a case study of Seva, the Self Employed Women's Association. In India, it is a strong example of NGO innovation. By linking women's health with livelihoods, Seva empowers women economically while addressing reproductive health. Through grassroots mobilization of women workers, Seva integrates reproductive health services into broader empowerment programs, demonstrating the interconnection between health rights and livelihoods. Sociologically, Seva operationalizes the capability approach. Income, bodily integrity, voice, and health are expanded together through collective organization rather than isolated services. In the informal economy, where women face gendered precarity, Seva's cooperative savings groups and insurance schemes build social capital and reduce the opportunity costs of seeking care, making contraception, antenatal, postnatal care, and referral more feasible. Its peer educators and member led clinics exemplify co production, turning beneficiaries into agents who define priorities, monitor quality, and negotiate with providers. By tying the health entitlements to economic security, Seva reframes reproductive health as a right necessary for decent work, not a discretionary add on. Programmatically, Seva style models track smart outcomes: contraception continuation, timely antenatal visits, reduced out of pocket expenses, alongside economic indicators like savings regularity and income stability. Politically, Seva acts as counterpublic, bringing women workers' testimonies into the policy arena to demand gender responsive budgeting, respectful care, and social protection for informal workers. This integration shows how livelihood platforms can become durable delivery channels for right based reproductive and child health, sustaining uptake and accountability over time. BRAC, it's a case study of Bangladesh. So, BRAC in Bangladesh is one of the world's largest NGOs. It has pioneered large scale community health programs with special focus on maternal and child health. BRAC trains frontline health workers who provide door to door services, including family planning, safe deliveries, and immunization. Its success shows how NGOs can deliver cost effective, scalable solutions in low resource contexts. Taking a sociological lens, BRAC exemplifies co production and task shifting. Trusted local women are trained, supervised, and compensated to extend the health system's reach, converting social capital into service uptake and accountability. Program design blends implementation science with livelihood platform so care seeking becomes economically and socially feasible for poor households. Door to door outreach fuses evidence and narrative. Disaggregated data on antenatal care, immunization dropouts, and contraception continuation are paired with household counseling that addresses norms, gender power, and safety. The model institutionalizes respectful care and informed choice, emphasizing consent, privacy, and grievance channels, while strengthening supply chains and emergency referral for obstetric and newborn complications. For scale and policy influence, BRAC codifies packages that governments can adopt, aligning with public financial management cycles and routine HMIS so results are visible and fundable. Finally, the success is tracked through smart metrics and paired with community scorecards and after action reviews, ensuring continuous learning and durable equity focused impact. Civil society plays a key role in promoting gender equality within reproductive and child health. Women's groups empower women to demand quality maternal services and resist harmful practices. Civil society organizations also addressed gender based violence, linking survivors to health and legal support. By promoting male engagement, they challenge stereotypes and encourage shared responsibility for reproductive health. Child protection is a central concern for civil society organizations. They advocate against child marriage, a major barrier to adolescent health, and campaign against child labor, which undermines child development. Civil society also promotes children's rights, ensuring child health services are not just delivered but done so with dignity, equity, and justice. During emergencies like natural disasters, conflicts, or pandemics, NGOs and civil society organizations play frontline roles. They provide humanitarian health services, including safe delivery kits and child nutrition support. They also protect women and children from exploitation and trafficking during crisis. Providing psychosocial support for trauma is another vital role. Their agility and proximity to communities makes them effective first responders. Civil society ensures accountability by conducting social audits and community scorecards where communities assess service quality. They track health budgets to check whether funds are being used effectively. Civil society also documents and reports rights violations such as denial of maternal care or discrimination. These monitoring roles keep the health systems transparent and accountable. The strengths of NGOs and civil society lie in their flexibility and innovation. Unlike large bureaucracies, they can adapt quickly to local needs and experiment with new approaches. They enjoy trust at the community level, enabling them to engage populations who might mistrust government institutions. Their ability to mobilize quickly during crisis makes them vulnerable partners. Despite the contributions, NGOs face limitations. Many are heavily dependent on donor funding, which makes their sustainability uncertain. The NGO sector is often fragmented, leading to duplication of efforts and competition for resources. Additionally, pilot projects may struggle to scale up or sustain themselves once external funding ends. These challenges highlight the need for stronger integration with government systems. These are problems of resource dependency and organizational field fragmentation. Incentives push NGOs to chase short-term grants and visibility rather than build interoperable systems and shared accountability. Practical correctives include harmonization platforms and formal memoranda of understanding that align NGO roles with district microplans, supply chains, and referral pathways. For sustainability, convert into institutional packages like SOPs, training curricula, costing sheets, and embed line items in district public financial management cycles with clear smart targets. Address scale barriers through capacity transfer, data interoperability with HMIS, and governance fixes. Finally, tie funding to equity and performance. Disaggregated results, community scorecards, grievance resolution timelines. So, government NGO integration strengthens right based delivery while reducing fragmentation and donor driven drift. Civil society also faces critiques. Some organizations claim to represent communities but may not truly reflect grassroots voices. There is always a risk of political co-option, where advocacy agenda are diluted by political influence. Questions also arise about accountability. While NGO demand accountability from governments, they themselves must ensure transparency and responsiveness to the communities they serve. Governments often partner with NGOs to extend services in hard to reach areas. Contracting NGOs for specific services or building public private partnerships has become common in RCH. NGOs are also included in policy consultation platforms where they bring grassroots perspectives to policy debates. These partnerships leverage the strengths of both government and the NGOs. In India, NGOs are involved in implementing national reproductive and child health programs. Under NRHM, NGOs mobilize communities for health service and support ASHAs in outreach. Many NGOs play key roles in ICDS and immunization drives, ensuring coverage in difficult terrains. By extending government programs, NGOs enhance the reach and effectiveness of RCH services. Building on this, read NGO rules through a sociological lens of co-production and social accountability. They translate rights into access by pairing state entitlements with community trust, local languages, and women collectives. Under the NRHM, NGOs strengthen last mile delivery by training and mentoring ASHAs, supporting village health, sanitation, and nutrition committees, and improving referral for emergencies while reducing opportunity costs for marginalized households. With ICDS, they help Anganwadi centers with growth monitoring, nutrition counseling, and take home rations, and community scorecards that make service gaps visible and correctable. In immunization, NGOs enable micro planning for hard to reach hamlets, track dropouts between doses, and support cold chain reliability and safe session sites, often using community leaders as trusted intermediaries. To close the design delivery gap, they institutionalize feedback loops, grievance channels, public hearings, and right to information support. So, frontline problems surface and are acted upon. Networking enhances the impact of NGOs and civil society. Networks of NGOs working on maternal health amplify advocacy for safe motherhood. Civil society coalitions campaign for child rights at national and international levels. Global advocacy platforms connect local voices to international agendas, ensuring grassroots realities influence global policies. The White Ribbon Alliance, which we talked about in the past, is a strong example of NGO-led advocacy for maternal health. With national chapters in many countries, it empowers women's voices and influences policy reforms. In India, it has successfully campaigned for respectful maternity care. This demonstrates how civil society can bridge the local experiences with global advocacy. Many NGOs work directly with ASHAs, training and support them in outreach counseling. This strengthens the linkage between communities and health systems. NGO support enhances ASHA performance, leading to improved maternal and child outcomes. Such partnerships demonstrate the complementary role of NGO that it plays in government-led programs. This is co-production in practice. So NGOs translate policy into usable routines, microplans, household registers, counseling scripts, while ASHAs contribute local trust and language, closing the design delivery gap. Addressing street level bureaucracy, NGOs provide supportive supervision, on the job coaching, and problem solving hurdles that reduce paperwork burden, clarify referral pathways, and ensure supplies reach households. Structured mentorship improves social capital and efficacy among ASHAs, raising timely antenatal postnatal contacts, early breastfeeding, immunization completion, and postpartum contraception uptake, especially for the first time and marginalized mothers. Equity safeguards are built in. Consent based counseling, privacy during home visits, and referral accompaniment for obstetric or newborn danger signs. Linking communities to functional, AMONC, and SNCO services. Performance is tracked with smart indicators, co-set with districts and feedback loops. Make results visible and correctable. By institutionalizing after action reviews and publishing simple dashboards, NGO ASHA partnerships convert scattered effects into reliable right based service delivery, strengthening their accountability while preserving community trust. Civil society plays a key role in linking local action with global goals such as the SDGs. They monitor government commitments and hold leaders accountable for maternal and child health targets. By advocating for inclusivity, civil society ensures that global progress reflects the realities of marginalized communities, leaving no one behind. Strengthening NGOs requires systemic investment in capacity building, ensuring staff are skilled in both service delivery and advocacy. Financial sustainability must be prioritized through diversified funding and integration with government budgets. NGOs also need stronger accountability mechanisms to ensure transparency and responsiveness to the communities they serve. The future of NGOs and civil society lies in expanding digital health innovations such as mobile based counseling and telemedicine. Strengthening community participation will remain at the heart of their work, empowering people to shape health services. Integration to universal health coverage frameworks will ensure their contributions are sustainable and embedded in national health systems. To summarize, NGOs and civil societies complement governments in delivering and advocating for reproductive and child health services. Their strengths lie in innovation, community trust, and advocacy. However, challenges of sustainability, accountability, and fragmentation remain. Strengthening their role requires collaboration, integration, and long term investment. In conclusion, NGO and civil society act as catalysts, driving equity and innovation in reproductive and child health. They extend the reach of services, advocate for rights, and bring community perspectives into health systems. Their role is indispensable for achieving inclusive and sustainable improvements in maternal and child health. As we close this lecture, I once again want you to reflect on the role of civil society in making health a right rather than a privilege. By amplifying marginalized voices and challenging systemic inequities, NGOs and civil society ensure reproductive and child health services are inclusive, equitable, and just. Their work reminds us that community driven action is central to achieving health for all. Thank you so much. This is all for this session. We continue with lecture number 45, which deals with capacity building for community health workers.